Everyone. I want to thank you so much for taking time out. For me, it's the afternoon. For some of you, it's the early morning to join us today on an exciting webinar focused around vaccine equity, breaking down access barriers. My name is Denise Octavia Smith. I'm a community health worker. I bring you greetings from Hartford, Connecticut. And in November I had the great honor of becoming the founding executive director of the National Association of Community Health Workers. The National Association of CHWs was founded in April 2019 to join together and unify CHWs, promotores, community health representatives, and our allies across sector, ethnicity, and experience to support communities to achieve health equity and social justice. And I have the honor today of being your host and moderator on behalf of the Vaccine Equity Cooperative. I want to take a moment and just appreciate the successes of our collective vaccine distribution efforts. To each person who has contributed to vaccine development, clinical trials, safety approvals, messaging, strategy development, community outreach, vaccine administration, I offer thanks and recognition for the unprecedented partnerships, the coordination and commitment it took to get us this far. Without a doubt, this includes having purposeful leadership from the Biden administration, as well as state and local actors, public and private. Today, President Biden increased his vaccine goal to 200 million within his first 100 days. Eligibility has been expanded, and nearly half of all adults have received at least one shot. Now, to the issue of equity. Last fall, I joined with health leads and dozens of other organizations and individuals to lift up the charge of equity in vaccine development and distribution. Our joint statement released in October 2020 called for public and private institutions to build trust through authentic engagement of Black, Latinx, Native, and all communities of color, tribal governments, public and private institutions, to ensure full and complete transparency about the safety and efficacy of the vaccine. We called for substantial resource investment to strengthen our local and community-based public health infrastructure. We also offered strategies to expand access, including expanding training and sustaining a U.S. community-based workforce, including community health workers, to aid in the distribution of the vaccine. Combining vaccine distribution with other essential resources, including mental health, expanding primary care capacity and access, and eliminating cost and all other barriers to vaccination. And we still have much work to do. And while many of us want to celebrate our accomplishments thus far, the data and the stories we receive from community-based organizations, CHW networks and associations, and individuals across the country confirm that we have much to do. The COVID-19 vaccination rate is nearly 3 times higher for white people than for communities of color across the US, and that gap continues to widen, despite communities of color being disproportionately affected by infections and deaths. Challenges in vaccine access and availability are further complicating distribution, particularly for institutions that struggle historically and in this current climate to really build trust. With all US eligible adults now eligible for the vaccine, trusted community-based workforce members and hyper-local data are even more critical to keeping equity at the forefront of vaccine distribution and breaking down these barriers. This webinar is part of a long-term strategy of the Vaccine Equity Collaborative to make COVID-19 vaccine, this moment, a movement for health equity and social justice, to provide curated and trusted resources messaging, and strategy for CHWs, community-based organizations, and all organizations who are pursuing equity in their innovation and partnerships during COVID-19. In this webinar brought to you by the Vaccine Equity Collaborative, our panelists will share national perspectives on vaccine equity efforts and spotlight local successes and lessons learned from communities in California and Florida, highlighting ways to build trust and expand access, the use of data and data dashboards and heat maps to identify and then remove access barriers, and the deploying of tailored messaging built with and for community. And so with that, I want to take a moment just to introduce our panel for today. Next slide, please. These are high-level summaries of the bios, but I invite you to learn more about all of our panelists through their organizations and their social media channels. Lauren Smith is the Chief Health Equity and Strategy Officer at the CDC Foundation, working across healthcare delivery, public policy, and the public health field. She collaborates with her team at the foundation to drive strategic efforts to embed health equity and address systemic racism across the foundation's COVID response. She's going to be sharing some of the latest national vaccine data and data on disparities as well, around, as well as some current opportunities for funding to support community-based organizations to increase vaccination coverage. I want to introduce Carolyn Murtagh. She's a project manager for the U.S. Health Accompaniment Unit of Partners in Health, whose work includes strengthening post-Ebola surveillance in Liberia and advancing healthcare as a human right. She returned from Uganda during the COVID-19 pandemic to support local governments here in the US, as well as organizations and communities to implement equitable COVID response. I want to introduce Julie Pedretti, Community Relations Director at the Healthcare Network, who joined the network after a 12-year career at the Children's Hospital of Wisconsin. In her current role, she directs activities to increase COVID testing and education in Collier County and builds relationships to meet community needs. I want to introduce Odeleste Gautier, physician and health promoter from Haiti, who received a Doctor of Medicine degree at the Pontificia Universidad Católica Madre y Maestra in Santiago de los Caballeros in the Dominican Republic. And I want to introduce Giveline Musaler, a health promoter who brings valuable knowledge from her experiences in healthcare delivery systems. As a CNA and care manager with the Pineapple House Senior Living, she's also served in roles as a documentation associate and medical records clerk. Giveline is a certified phlebotomy technician and medical assistant who lives in Immokalee, Florida, I hope I said that right, with her 6 children, and is a bilingual health promoter in English and Creole. Thank you in advance to all of the panelists who are going to be sharing your expertise today. I look forward to your presentations, and to all of our guests, over 220 now. We'll have an opportunity after brief presentations to open it up for questions. Please feel free to advance those questions through the chat. We'll be sharing links as well, and some of our back-end support staff from Health Leads will also be responding to some of your urgent questions as they are able. Thank you again for joining us. You're just muted, Lauren, but we look forward to hearing from you.
Thank you. Thank you so much for that introduction. And I'm thrilled and honored to be on this panel with such a great group of really committed and activist public health leaders who are doing such great work. Let me just take you through a little bit of data, as Denise shared with you, and give a little bit perhaps of a foundation for our conversation. So next slide. I wanted to start with just where we are, which is, I think, what Denise was also talking about, which is, as of yesterday, At least 133 million doses have been administered around the country, which is 40% of the people have gotten at least one dose, and 86 million, or almost just over a quarter of people have gotten are fully vaccinated, either 2 doses of that regimen or 1 dose of the one that requires only 1. So that's amazing and good. And we have reason to celebrate in all the ways that Denise mentioned. But there is another story to tell, and that's why we're all here today. Next slide. So we know, and the data shows, that the vaccination has, although we have a safe and effective vaccine, it has not been uniformly or equitably taken up among all of our populations. And so this slide demonstrates the difference between the gray bars, which is the percentage of the US population who's in that particular category, and the blue bars, which is the percentage of people in that group who are fully vaccinated. And so you can see that for the groups of color, the blue bars are less than, are smaller or lower than the gray bars. We have this data from over 86 million people. Part of the problem, though, with our data here, and this is something I'm sure you've heard about and been aware of, is that just under 60% of the information for race ethnicity was available. So we don't know what the race ethnicity is for almost 40% or more than 40% of the people who've been vaccinated. So that tells us that we have a big hurdle to get over in terms of collecting this information so we can hold ourselves accountable and track how we're doing. Next slide. So what I wanted to show here, and to be able to start to dig into, I think, the issues that the other panelists are going to bring up, is to confront the idea that the pattern and intensity of COVID's impacts in our communities is not a surprise. It is predictable. This graph shows in different colors the rate of deaths due to COVID-19 per 100,000 population over time. The main things I want you to see from here are, and the rate is stratified or divided by levels of social vulnerability. The CDC has a social vulnerability index. Low vulnerability is the purple line, and the highest vulnerability is the teal or blue line, and in between you have the green or moderate vulnerability. What you see is that across the whole span of the time, and especially since June, you can especially see it in the big peak in last summer into the fall, and now the big peak that happened over the winter and late winter and early spring, that blue or teal line is above for across all of that time. That means that the folks who fall into this category of high social vulnerability are the people who are literally dying at the highest rates of COVID. So it's not a surprise what goes into this social vulnerability. Next slide. It's the very things that you are working on and that you would know. Things that include socioeconomic status, like poverty level, unemployment, level of education, household composition. That is, are there people there who are older and perhaps more vulnerable and frail, or younger similarly? Housing and transportation. Is there crowding? Are families having to live doubled up? Are they living in quarters where they don't have space? Do they have a car? Do they have transportation to be able to get to places? And race, ethnicity, and language, limited English proficiency, and what the CDC identifies as minority status, essentially populations of color. All of that goes into that social vulnerability index. What you see here, though, or what I want to make clear, is there's nothing in here about health. There's nothing in this social vulnerability index that says, hey, do you have heart disease or diabetes or any of those other things? Yet it still is the strong predictor of death due to COVID. And that's because all of these kinds of factors contribute to whether or not people have the opportunity to be healthy before COVID and put them at risk to having serious outcomes from COVID during the pandemic. Next slide. So when we think about the vaccination system, you then go to think about, well, how does inequity get into something that's seemingly as straightforward as getting people vaccinated? Well, as you step through and you just saw what that social vulnerability index is, you can think of all these things, or you can identify all these things. So access to the internet, ability to have broadband, or ability to have a laptop, or to be able to negotiate being on the internet, not having cars or ability to get to the large vaccination sites that might not be in their neighborhood, not being able to speak English well, to be able to, again, navigate websites or other systems or phone sites that are in English only. And then for those folks who are undocumented, who may have additional hesitancy around seeking care or interacting with others because of the fears that they have understandably have regarding their immigration status. So there's so many things that can go into interrupting what could or theoretically should be access. Next slide. So what is the role that a foundation can play in this kind of situation? And at the CDC Foundation, we really feel like there's multiple roles that we can play. And I'm only gonna, bring up a few of these, but acting as a convener, bringing information to people to bring them together, being able to bring groups together that might not ordinarily wind up in the same place, in the same way that health leads and the National Association of Community Health Workers is doing now in terms of bringing groups together. Being an activator or catalyst to try to move thinking. And of course, being a grant maker and a program implementer. Next slide. One of the things that I wanted to make sure that I shared with you today is to be transparent about what our principles are at the CDC Foundation in terms of how we want to be doing our work. And this gives you a snapshot of them, but the ones that I would want to really highlight for you are the idea of authentic community inclusion and engagement, and the reckoning with historic and current experiences that result from systemic racism. The importance of focusing on the building blocks of health, which I know and I can imagine the panelists are going to be talking about, and then thinking about the cross-sector collaboration, working between public and private sector, between health and healthcare and public health and all the other sectors that have an impact on all of those other experiences that we talked about. Next slide. So we as the foundation recognize the importance of supporting community-based organizations to promote healthy and resilient communities for multiple reasons, but perhaps the two most important is that we know that community-based organizations have deep and trusted connections with community members. As Denise pointed out, they are trusted communicators and they can provide hyper-local data and execute on hyper-local strategies as well and are trusted to do so. And we also know that community-based organizations that are led by and focus on people of color, they need the resources ongoing to be able to make the infrastructure investments to sustain their important work. Next. So we have been building, focusing on how we can build capacity and resilience through grants, supporting the development of sustained and inclusive partnerships, which hopefully we'll get to talk about, and supporting them to be able to partner with advocacy and policy organizing groups. Many community-based organizations are doing amazing work, but don't necessarily see themselves as doing health work. They might be doing other kinds of grassroots organizing, and being able to sort of support that bridge is really important. And then being able to be the cheerleaders and galvanize support for these organizations to convey what an incredibly important role they play in community well-being. Next slide. So I wanted to not leave before sharing with you that as an example, we have a request for proposal, an RFP that's out now that will support up to 100 community-based organizations across the country with $50,000 to $100,000. The due date for this is May 3rd. I've included the website here so you can go learn more about it, but the focus is specifically on supporting community-based organizations to increase vaccine coverage in those communities of color that have been left behind in some of the outreach or the administration of the vaccine that we were just talking about. Next slide. I also want to call attention for community-based organizations that there's a wealth of resources that are available on the CDC websites that folks can use and adapt to their own purposes, posters and buttons and all sorts of graphics. Next slide. And there are, this is just a snapshot, but there's information in Spanish, there's information in other languages, and specifically for community-based organizations and groups that are working with communities of color. Next slide. So with that, I'll end. I just want to say I look forward to the discussion, and I'm so excited to be having this conversation with you, and look forward to hearing what the other panelists have to share.
Lauren, thank you very much for joining us today. A couple of questions have come through to the chat. I've answered some, and there may be one or two also directed to the CDC Foundation. We'll have an opportunity for additional questions for Lauren after the other presentation. So I want to bring forward now the Partners in Health and Healthcare Network team. Thank you so much for joining us from Immokalee, Florida, I believe it is. And the entire group will present. So let's just be patient, and we'll have an opportunity to hear from each of the partners who are with us today. Welcome.
Hello, thank you for the opportunity to participate in today's webinar. It is Immokalee, Immokalee, Florida, and I'm going to do just a very quick overview of Immokalee, our geography, and about Healthcare Network, and then turn it over to the team that does all of the work out in the community. So if you would go to the next slide, please. Immokalee is located in Southwest Florida. We're in Collier County, which is a very large county. So from the southeast, Naples to Immokalee is about an hour's drive. Immokalee is a farm community, and I'll talk more about that in a minute, but let me tell you a little bit about Healthcare Network. It's a federally qualified healthcare center. We're one of 1,400 FQHCs across the country. We were founded in 1977, specifically to take care of the migrant farm workers. So our history is deep in the Immokalee community, but we also have the same type of services for the vulnerable populations, the underserved populations in other parts of Collier County. But we've focused with Partners in Health on Immokalee. And if you would go to the next slide, please. The area is, it's about 29,000 population during the high season, during the growing season. People come here to do the farm work from October until about early May. So people are starting to head to other places now. You talked about social vulnerability index. We've got so many of those factors right here. Crowded conditions, lots of food insecurity, lack of transportation, just lots of issues that as community health workers, we're trying to address in the midst of the COVID pandemic. We'll talk more about this in a moment, but here there are lots of barriers to, first of all, testing for COVID and now for vaccinations. Registration systems, events that take place during the day when people are working. Again, transportation is a huge issue, technology is an issue, and the population here is very, very high poverty levels and language barriers. So about the people that we're dealing with in Immokalee, about 40% speak Spanish, 40% Creole, and 20% English. And that's a reason why for our community health worker team, we need to have bilingual, and as you'll meet Odie, he speaks 3 languages. So it's just been important to have that cultural sensitivity, language sensitivity, and understanding the population that we serve. You can go on to the next slide and I will turn this over to Caroline.
Hi everyone, my name is Caroline and I work with Partners in Health, but I've had the honor and the privilege of working alongside the healthcare network and our team of health promoters here in Immokalee throughout the COVID pandemic. And I've learned so much from them and I'm really excited to be part of this panel today. And so just to build off what Julie shared, we just wanted to highlight sort of the real impact that some of these barriers to vaccination have had in the Immokalee community by telling a story about the first attempt that was made to bring vaccination to Immokalee. And so the Department of Health set up a system that initially had been based in Naples, and then the idea was to bring the same sort of registration system to Immokalee. And so unfortunately, it was an online registration system that initially was only in English and required, technology, internet, and English language capacities. The registration also opened at 9 in the morning when a lot of people were at work. So as you can imagine, it was really difficult for people in Immokalee to access appointments for vaccinations through this system. And so as you can see on the right of this slide, the result was that the site was flooded by outsiders, mostly from Naples and Fort Myers, and only one person in Immokalee was vaccinated. And so the important takeaway, I think, for our team from this experience was that vaccine hesitancy is different than vaccine inaccessibility. And so a lot of people, when talking about this sort of anecdote, would say, well, there's a lot of vaccine hesitancy in Immokalee, people don't want the vaccine. And our team was able to push back and say, no, people do want the vaccine. This is a question of vaccine inaccessibility and how can we build structures that can support people to access vaccination. So again, this is kind of set the stage for the initial approach. And then I'm excited to talk with our colleagues about some bright spots that we've been able to see since then. But we can go ahead to the next slide, please. So then just to zoom back a little bit before highlighting some of these bright spots that we've been able to support with our team in vaccination, we just want to talk a little bit about our health promoter team. So in Immokalee, we often talk about the idea that the last mile is not just about distance, but as Dr. Smith highlighted, it's really about vulnerability, political, social, economic vulnerability. And so we've been able to partner with an awesome team of health promoters who have been able to help us to sort of bridge the gap between the healthcare system and the community. And because our health promoters are from Immokalee, we understand the social and structural context and can really help people to navigate some of these systems to overcome barriers to care. Our health promoters have also helped a lot in raising awareness for some of the underlying structural causes of health inequities. I know I've learned a lot from our team about what barriers exist and that people can offer their lived experiences and really partner with the community in building a healthcare system that works for the community. And with that, I'm really excited to turn it over to Odie, who's one of our health promoters, and can maybe share a little bit more about community health workers and then also some of the bright spots we've had with vaccination.
Okay. I am Odie. Time before, with the appointment vaccine, we have a lot of barrier, let's say language barrier, online access barrier, and in Immokalee, the youth population is vulnerable as age and transportation barrier. Now, what we do in Immokalee, when we canvassing, we take the name and we make the appointment, and day before the appointment, we call them to remind them. And since sometimes they have language barrier, and so I speak Creole and Spanish, and I try to help them mostly I can, because just call them from another phone call, they're afraid to answer because sometimes they text English, people gonna talk to him. We call them day before, and sometimes, as the Dr. Smith said, we focus medical perspective, let's say we focus on the disease, we don't focus on social board. As combined before with Ms. Julie and COVID team here in Immokalee, we try to help those people and fight them, avoid those vaccine hesitancy, and try to help everyone not based on age, not based on only capacity, but everyone can have access to the vaccine. And other part, I can say by my experience in PIH, because I've been working in PIH for 2 years after my medical school, the social part is really important. The social part, sometimes we focus on those diseases let's take an example. We have someone with asthma because the part of the house are the problem of the asthma. They have the pollen in the house, or we don't visit the house, like, or they leave. But focus or they leave sometimes we reduce like those problems. Like the social part here in Immaculate, we've combined effort with Miss Julie and COVID team. We try like to help all those population and needs undeserved people.
I think we can go to the next slide. Thanks.
That's what I thought.
So this just provides an overview of like what Odie just shared, but about this idea of doing the active outreach in the community, whether it's through door-to-door canvassing to households, visiting churches, or announcing information on the radio to build this list of people who really, want to get vaccinated, but just need the structures to get there. And then our health promoters like Odie is being humble, but he's called hundreds of people in the community to schedule them for appointments, to remind them of when their appointment's taking place, and even to arrange transportation to get people there. And then at the vaccine events, our health promoters are also there to really accompany people through the whole process, reading them in their language, giving information, that really makes sense within the social and structural constraints that we're working. Now we're excited to talk with Jay about another model that we found to be effective with vaccination. And so we can advance to the next slide, please.
Well, I'm Javelin. I go by Jay. My experience with the vaccine and also the promoted the walk-up is very accessibility to the community. Sometimes like to make the appointment, like you could call them and then next thing you know, they said it's not appropriate with the time of schedule of the work. And the hours for the vaccine, sometimes when they get off from work late from the farms and then they have we're already closed for the vaccine. So the walk-up vaccine also is a great opportunity for them to come and get the vaccine. What they really, they're not scared to be on the line, like the size of the crowd of the line. When they see other people in the line, they willing to join the line to come and get the vaccine late. And they don't really ask a lot of questions because of based on the document, some of them, they kind of scared to come and get the vaccine. So they really like the fact that it's more for walked up to get the vaccine. And then the last part, like they going up north. So a lot of them really, right now, they willing to get the vaccine.
Mm-hmm. Yeah, thank you so much, Jay. And now we can advance to the next slide, and Julie will take us through the last model that we found to be effective.
We were able to work with the local growers to schedule, there was a question about J&J vaccines. We were able to get a good supply of vaccines. We worked with the growers to schedule buses to come in from the fields with the farm workers to get vaccinated. And some of the buses were unable to show up because people had to stay out in the fields. So we had some open positions and we were able to call and contact and canvass and bring additional people in. So it was a little bit of a hybrid between addressing the growers and the packing houses and getting people in and being able to open up some of the slots because we wanted to use those vaccines that Saturday. So that was a Saturday event, and some of the other walk-up events that were described were Saturday events too, to meet the needs of the community, actually Saturdays and Sundays, because time of day and day of week are important to people who are working out in the fields. So we're probably going to do another walk-up vaccine event. We'd like to go back to J&J as soon as it's reapproved, if it becomes available. But if not, we're going to go ahead with the Moderna. We believe it's better to get them vaccinated at least once before they head north, and hope that there's some assistance to them in not getting COVID.
All right, so now we can go to the last slide, please. Great. So we just, to take us home, we just really want to emphasize the importance of going the extra mile to reaching vulnerable individuals, as Odie highlighted, really thinking beyond, traditional constraints, I guess, in medicine and really addressing the social determinants of health. And so for us, I think the takeaway is that vaccine equity is about reaching people with the method that works for them. So rather than use a one-size-fits-all approach, even between Naples and Immokalee, even within Immokalee itself, we found multiple different methods for reaching people that are more effective for different groups in the population. And so just to give a few final anecdotes of the work that we've done to really go this extra mile. So again, as we talked about, health promoters arranging transport for patients to get to sites. We're canvassing every day, door to door, promoting vaccination events and really connecting with community members and trying to understand what barriers they're facing so that we can give that feedback to the clinic and build structures to overcome those barriers. Something exciting that we're talking about doing in the future is converting our mobile testing unit into a mobile vaccination unit, which again would allow us to bring services directly to the community at residential areas, churches, marketplaces, at times that are convenient for people, which is often after work or on the weekends. Odie and Jay, do you guys have any closing thoughts too on any experiences with vaccination?
What I can say, like, we try to reach those people, like as just said, sometimes those people just afraid to give their name because based on a identification paper, and we try to reach them when we talk to them, like conversing, they more easy to get their name and to find access for the vaccine because they feel it's not someone like try to make something bad to them toward them. Like we try, when we converse, we make them comfortable and talk to them, like try not convince, but as a social worker, let them know what we are doing.
Odeles, Jeveline, Caroline, Julie, thank you so very much for your presentation. I want to bring Cami forward, but I want to direct your Immokalee team to the chat. There are some questions that have been lifted up there that you may have an opportunity to answer. Cami, thank you so much for joining us from 211 San Diego. Really excited to hear your presentation. We've had lots of questions around data already and the power of data to drive tailoring of access. So welcome to the webinar.
Thank you. Thanks so much for having us. And good morning from the West Coast. It's still morning. I'm Cami Christensen. I am a 2-decade social worker here in San Diego, and I've been with 211 for 10 years. And I'm here to share our firsthand frontline experience during the COVID pandemic and the vaccine rollout. Real briefly, San Diego County is a border town in the southern part of California. We're home to 3.4 million San Diegans. Our county is the same size as the state of Connecticut, and we are the 5th largest county in the country. We're a very diverse county. We have 18 tribal nations, 18 cities and municipalities that make up our county, 42 school districts, and the region is very, very diverse with the largest refugee resettlement site in all of California. And our residents speak over 100 languages. And San Diego is home to the busiest international border crossing in the world. Next slide, please. 211 San Diego, if you haven't heard or don't know what 211 is, I encourage you to find out and reach out to your local 211. Our mission here at 211 San Diego, we are a private nonprofit. We serve as a nexus to bring the community organizations together to help people efficiently access services. And the second half of our mission really proved critical during the vaccine rollout. And the second half of our mission is to provide vital data and trend information for proactive community planning. Most folks are familiar with 211 during an individual disaster like being housing insecure, food insecure. We've also here in California take on a large role during community disasters like wildfires and smaller public health crises like H1N1. And here in San Diego County, we had a Hep A outbreak in our homeless population. Those relationships and experience over the last several years really forged a great partnership with our local county government, our Health and Human Service agency at our county. We're lucky to have one umbrella organization for our county government, HHSA, that includes the public health department, as well as our eligibility department and our housing. And that close partnership really came to play when the outbreak and the pandemic happened. The other piece there on the screen is our community information exchange. That is an ecosystem that was developed way back in 2011. And today is a network of over 104 different organizations, multi-service organizations, that are all working together in real time for resource updates, electronic referrals, and the CIE, this Community Information Exchange, allows the system of care to be much more nimble and reactive. And that was really, really helpful during the time of the pandemic. Next slide, please. Our role really changed in COVID response. We were first activated by our county to be that one place to call for questions back in January and really ramped up in March when the California stay-at-home order happened. Our typical call volume, so we're a 24-hour hotline. Our typical call volume in any given day is 1,200 to 1,500 calls a day. Once that stay-at-home order was mandated for the entire state, it really tripled to about 5,000 calls a day. The initial questions were about transmission and how is it spread and public health orders. What does it mean? Can I leave my home? And we were having to be very nimble and really leverage our infrastructure around getting the information out and responding to the social service needs, the meal deliveries. We had seniors that were now at home and folks needing income assistance. One of the things that CIE allowed us to do in that moment was we could see where there was an off balance of supply and demand. We now had service providers that were essentially shutting down direct services because of the stay-at-home order, where we were able to remobilize those folks, that service, and change the service delivery so that they were instead of transporting people to medical appointments that were no longer happening, they were transporting meals to seniors who were stuck at home. And so having that infrastructure really allowed us to set the stage for a vaccine rollout, but also allowed us to be nimble and to meet the demands of what was going on. We relied initially on those days on our county public health department. Because of our call volume was so high and our, sorry for getting dizzy by the slides. We had our county public health nurses answering calls with questions around how is it spread in their very, very early days. And that partnership with our county public health nurses really proved helpful in the testing and vaccine rollout. When we transitioned away from kind of everyone knew what COVID was, we transitioned to testing, which also proved to be a good initial use case for the vaccine rollout. Our role at 211 was letting the general public know about the process for testing, how to get referrals, how to schedule an appointment. People were concerned about getting their test results and really escalating questions. And the critical piece was that trend reporting back to the decision makers around what the callers were calling us for, what the needs were, what the unmet needs were, callers needing isolation rooms, transportation to testing sites, and folks that were uninsured and very nervous. That really led to the tsunami of the vaccine demand that really hit us back in late January of this year. Our role in vaccines really, again, helped with the testing, allowed us to have this foundation. But our role in that testing was around being very clear with who's eligible and who's not for vaccines. There was a very complex color coding system in the state of California about phases and eligibility. So folks are very, very eager. We had a new population of folks that called 211 that had never called before. It was usually folks that would call 211 was economic based. They had economic needs, whether it was homeless shelters. And this was the great neutralizer. We had folks from very affluent areas calling us, wanting to know when it was their turn, when can they get an appointment. So we had to be very mindful of rolling out information and assistance in a very meaningful way that would be most impactful to our community. We deployed our navigation advocacy program. If you can see on the slide, why don't you just go to the next slide, please? The vaccine scheduling there, maybe that will be stable. So we saw a lot of barriers that were in scheduling the vaccines. When initially it was vaccine appointments were available locally, and you had to get online and schedule an appointment. And it was what I likened it to a radio contest. Whoever had the fastest internet speed, whoever had the most capability. But on top of that, there was a lot of scheduling systems, appointment setting softwares that required specific data fields in order to move on to schedule an appointment. And so locally at first, we had 4 different appointment setting softwares, each requiring different data elements. One of the appointment setting softwares required a social security number, when we know that that was not required as a eligibility requirement. So our role was to demystify and break through those fears and those barriers and help them and put in the 9999999 for a social security number, just to get past that equitable concern of who is eligible and who's not. The systems also required emails and cell phones to authenticate themselves in that moment. And so they couldn't move past a scheduled appointment. So we began actually having our agents do that direct appointment, vaccine appointment scheduling. And we used our own emails and we used our own cell phones just to get folks past that barrier. And then what was critically important was tracking that information. And what you see there on this screen is telling the health systems why their appointment software is not working, telling our county this is what is problematic, and giving that information in very actionable ways and in geography-based ways so that they could then adjust where their sites were for appointments and eventually get to a place where we can have sites that don't require appointments to break through that barrier. One of the things that we also did for accessibility is created a interest list or wait list for folks who were homebound. We had a large volume of callers who had spent the last year being told not to leave their homes, and now, especially seniors, felt very vulnerable in going to a mega site or super station, as it was called at the local San Diego Padres stadium. And so we also had some folks that were not able to leave their home. So we created a wait list that was easy accessible. Call 211 24 hours a day, and we'll get your information and get that routed to those providers who are able to go into your home and vaccinate you in your home. We also have a language line where we're able to communicate in over 200 languages. So to break through those barriers, we also are able to, at the point of care, if someone's at the vaccine site, they are having translation issues, they can call us and we can help them if we set their appointment. We also noticed very early on that there was a huge volume of transportation needs. So we worked with our local, with actually the United Way Worldwide and Lyft, and started coordinating direct transportation assistance. And on average, we're spending about $25,000 in rideshare programs, just getting people to and from their vaccine appointment. So we made sure all of the county vaccine sites had very clear delineated signage that says this is where you pick up and drop off for those sites that were that we were providing transportation assistance. One of the key things that we did was advocate for set aside appointments. So getting out of that radio contest of who's going to be that first caller to get that vaccine appointment, instead of having the 2-on-1 agents kind of compete in that same race, give us set aside appointments at the locations. And we have filled those appointments within the first day. We also worked locally with several different PACE programs so that they did not open their appointments to the general public. They removed themselves out of that race and only allowed us to screen for and make appointments. So we could screen for eligibility for seniors, for those that had mobility issues. We have one site that's for refugees specifically, and we screen for them and make sure that they have the assistance and the concierge service that's needed. And that partnership allowed us to serve the critically, those folks that were most impacted by COVID and those that were having the most difficulty in getting the different normal general public appointment setting processes completed. Next slide, please. Here's just some data. This is statewide information. So these are all the 2-in-1s across the state of California. You can see the call volume, that red line for the healthcare need. This is from May of 2020 to March. And you can see the blips in the need for healthcare related information. And that's pretty consistent across the entire state. It's off the charts in January once the vaccines came. And then the statewide information was really helpful when we talked directly to those, the supply issues. So who at the state was disseminating the actual vaccine supply, we could show state level information around where are their barriers, where are their needs, and the email and the internet, the email and the internet access issues. We were able to talk through as the state was mandating one particular software. Let's make sure that that software, we learn from lessons learned on the front lines, and let's not require certain fields like an email or a cell phone in order for folks just to make an appointment. And that state level data was critically important. Next slide, please. Here's San Diego specific information again around the need. The first graph is from June 2020 to April 2021. And that just shows the volume of calls. Our highest volume of calls that we've ever received in the history of 2-in-1 was when a superstation was opening in an affluent area, generally an affluent area. And we had 14,000 calls in one day because everyone was very excited and wanted to make sure that they got a chance to get to that appointment. And so we really worked hard to screen for and make sure that we are leveraging our assistance to those seniors, those folks that have language barriers, and using our set aside appointments to target those most in need. That second graph there shows, again, the volume of need is that yellow line is for vaccines in comparison to the testing, even well before vaccines were in our community. The testing and test results pales in comparison to the interest and need for vaccine related information. Next slide, please. The second half of our mission, again, is providing that vital trend information. It's as critical as our direct services, and being the voice for our callers and the people who are interacting with our community information exchange system providers is critically important. And what you see here is how, as we were trying to figure out how do we get the information that's ever changing out to the community, we needed to make it an efficient process for our callers and our agents, but we also had to collect data so that we could inform key stakeholders. So we needed to understand, why are we not able to schedule appointments? What are the barriers? We had to explain why we were asking for racial and ethnicity information and zip code information, because folks were distrustful. They were thinking there was going to exclude them from a resource. And we had to make sure that it's so that we can share this information to allow for deeper analytics around disparities and unmet needs for particular populations and neighborhoods. That first category of information, or that first chart you see there, is why are people calling us? First appointment, second appointment. There was a lot of concerns and problems with getting folks scheduled for the second vaccine. The unable to schedule, why are we not able to schedule for folks, and breaking that down by ethnicity, and also what information is required, and why are we not able to make appointments based on the appointment software. So this vaccine call trends is something that we share widely. We share with our county every day. We share with anyone and everyone who will ask. Next slide, please. I know we're short on time. This is just a graph of our set aside appointments that we show to really highlight what are the need of folks that needed transportation. How are we filling the set aside appointments to really advocate for additional appointments. And really this next slide, please. This is the barriers. So if you look at this, this is a San Diego County heat map. 1 in 3 of our callers did not have an email. 1 in 7 did not have a cell phone, and 1 in 11 did not have a social security number. And for us to take this to the state and show this while they're planning really statewide information for our softwares, and take this to our county to help help them place where the sites are needed and really speak to the impacts of requiring that information and the assumptions that all callers or all San Diegans have that really helps shape the system and allowed for key stakeholders to fully understand where we could do better as a community and how systems maybe inherently block folks from access. Next slide, please. We are making progress. There are some stats. We've scheduled over 10,000 appointments. We have a list of homebound San Diegans that are 1,800. I think we're about halfway through getting those homebound seniors and San Diegans vaccinated. San Diego County is doing great for vaccine acceptance. And we have our target locally here to fully vaccinate 75% of our county by July, and I think we're on target for that. Next slide, please. There's just a list of recommendations. I'm happy to answer any questions, but here's just some frontline recommendations from our perspective. And in the interest of time, I will turn it over to you, Denise.
Thank you so much, Cammie. I know the time got away from us, but really that just shows that we needed more time to be able to learn from one another and to share all that we've been able to glean during this national effort to vaccinate everyone who's eligible. I was writing my own list of recommendations that have come from each and every one of you. But what I want to say to all of the participants, first of all, thank you again for spending time with us. We're going to come together to make sure that the questions in the chat have been responded to. Many of them have already had answers shared, but we'll go back through and share that FAQ as well as all of the slides. And what's critical is that we continue to analyze and consider how we can make quality improvements, how we can drive equity, and how we can sustain some of this innovation, some of this community-centeredness to address the social vulnerability that was here before the pandemic and will be here on, into the foreseeable future unless we make this moment of COVID-19 a movement for equity and social justice. There's a poll there. If you have time, please complete it for us on your way out. Thank you again for joining us and look for that email in the coming weeks with our responses and follow-up. Again, thank you to all of the panelists. I so appreciate your thoughtfulness and your efforts to share with us the shortcomings, the lessons learned, and all that you're going to do on to the future to ensure equity in this vaccine distribution across the country. Thanks again, everyone. Stay safe. Keep your masks on, get vaccinated, stay safe. Take good care.